Well, good afternoon, everyone. I think we should just start promptly. The room is still warm from the previous session, but I think we could start. So welcome to the Asia Pacific Chapter session. I'm Lillian Cao, and I'm going to be moderating this session with Professor C.C. Wang. So we've got two debates for this session. The first debate will be discussed by a number of people, and then we'll follow by the second debate. So I'm going to call on the first two speakers. Are they in the room? Li Yangzhu and Mufi? Yes, Li Yangzhu is here? Okay. So the first topic that we're going to talk about is, should Asian patients with BMI between 25 and 27.5 with comorbidities have metabolic and bariatric surgery? So each debater will have 10 minutes each, and then we'll spend the next 10 minutes with the discussant. So I'm going to invite Dr. Zhu to come up for the pro.
And I'm here on the behalf of Dr. Zhu to present Dr. Zhu's opinion about the lower BMI patients with comorbidities have metabolic and bariatric surgery. I'm Dr. Yang from Guangzhou. I'm going to present in these three contents. And for the characters in Chinese population with type 2 diabetes, as we know, it's different from the Caucasian population with type 2 diabetes. Maybe in the North United States, the mean BMI of type 2 diabetes patients should be higher than 30, but in China, in mainland China, the mean BMI of type 2 diabetes should be lower than 24. So it's very different for the Chinese type 2 diabetes patient with the Caucasian type 2 diabetes patients. So as the guideline with ASMBS and IFSO updated to decrease the BMI for the Asian population for metabolic surgery lower to the 27.5. And in Chinese, for the Chinese guideline for the type 2 diabetes with the BMI 25 to the 27.5 should be considered for the bariatric surgery. That is Chinese guidelines for the type 2 diabetes. So we ask the question because it's very different for Chinese type 2 diabetes population. So can we lower the BMI to the 25 to 27.5 to receive the metabolic surgery? My opinion, Dr. Zhu's opinion is yes. So here is some papers. Some papers was from the Asian population. Some papers was from the Dr. Zhu's team. They made, the first paper is a meta-analysis. From this paper, we can see that this meta is analyzed by Dr. Zhu's team. And from this paper, we can see that their team has proved that type 2 diabetes patients with a lower BMI could achieve benefits from gastric bypass during a long-term follow-up. The long-term follow-up for the more than 5 years follow-up, for the 6 years follow-up I think more than 60% patients can achieve better resolution of the type 2 diabetes. And for this paper, we can see, can low BMI Chinese patients with type 2 diabetes benefit from laparoscopy gastric bypass surgery? His answer is yes. This paper published in 2014. So from this exploration, we can see gastric bypass may beneficial in type 2 diabetes with BMI lower than 27.5 in small sample size. So, and for a short-term exploration from this paper also conducted by Dr. Zhu's team, the effect of bariatric surgery on Asian patients with type 2 diabetes with the BMI lower than 30. This is a meta-analysis. We can see the Asian lower BMI patients with type 2 diabetes can achieve significant weight loss, control blood glucose and lipidemia remission, and improve beta cell function. But the long-term follow-up are needed. So how about the long-term exploration? This exploration also conducted by Dr. Zhu's team. 52 patients with type 2 diabetes underwent gastric bypass between 2008 and 2012. Weight, BMI, GOGTT, HbA1c, and lipidemia parameters were measured at the baseline and 3 and 6 months after surgery. And the findings from the findings we can see that gastric bypass may be a safe and effective treatment for type 2 diabetes patients with a lower BMI in China. However, long-term study without loss of follow-up is necessary for better evaluation. So for the 6 years follow-up, it's really low. It's just the follow-up for 6 years just more than 20%. So, and this is a clinical study. For the clinical study, we can see after gastric bypass for the lower BMI patients, the fat tissues are redistribution. For the whole fat mass decrease and the trunk fat mass decrease and the arm leg fat are increased after 5 years. So this is the findings. For low BMI patients with type 2 diabetes, gastric bypass lead to a reduction in the total fat mass. Metabolical healthy fat redistribution occurred in 5 years after gastric bypass. May be a promising mechanism to explain the lasting benefits of gastric bypass for type 2 diabetes with lower BMI. So for the single experience from Dr. Zhu's teams, he can see increased risk of bleeding in type 2 diabetes and when gastric bypass. And how to select the appropriate patients for the lower BMI metabolic surgery and select of the appropriate patients in a good start. Low BMI type 2 diabetes patient selection including ABCD scores and functional assessment for the pancreas beta cells and vascular contractility. So if the patient with a good beta cells function recommended to have the type 2 diabetes, to have the bariatric surgery, but the function isolated beta cells is not that good, and the vascular contractility is not good. So this patient should not be taken with the bariatric surgery. And for the patient with functional isolated beta cells, good isolated beta cells, but with poor vascular contractility, this patient should be considered, but should with caution. So, and this is the how to prevent for the bleeding after a sleeve or after the bariatric gastric bypass. The serous suture should be benefits for the decrease the bleeding rate up for the metabolic surgery. So this is the experience for the robotic surgery. The first domestic robotic in China, the first domestic robotic system in China development by Dr. Zhu's team. So let's get to the conclusion. So should lower BMI with comorbidities patient have metabolic bariatric surgery? Maybe the selection, the fine manipulation, and the follow monitoring with the can achieve better outcomes. So that's my present on behalf of Dr. Drew's team. Thank you again. Thank you.
Okay, thanks. Professor Murphy will say hello, please. Also, we'll allow Professor Murphy from India.
Okay. I think actually my friend Jinji has done me a huge favor. He's actually spoken about all the low BMI, which is already there. I do agree below 35, below 30, that's all fine. And we're talking about below 27.5, that's a separate animal. That's a separate thing that we need to discuss. And that's what I'm going to discuss out over here. I completely agree with him that below 35 and below 30, we should be operating in Asia especially. But let's look at, that's my case mix slide. You can see that majority is Romaine gastric bypass. Well, these are the eligibility criteria that existed so far. If you look at the Asia Pacific region, we already had guidelines. Kazu sitting here was one of the person instrumental in getting these guidelines of below 35 and below 30. So we had a drop of 5 BMI points, and we were already doing low BMI work. The question was that up to 27.5, we were operating with inadequately controlled type 2 diabetes. So we already had that section of patients that we were doing operating on. Did this add any numbers to our cases? Well, except for a few regions, I don't think it completely added. The average BMI we were still operating was above that 40 mark. And then came the IDF, which was the first non-surgical association that actually prioritized patients in terms of their metabolic potential, and that was very important for us as Asians. And they, again, discussed about dropping the BMI points lower, but all up to 27.5. Then came the DSS-2 guidelines, and what do the DSS-2 guidelines again do? They recommended the same thing. They recommended that you need to prioritize patients, again, up to 27.5 BMI points, giving us a huge, huge option to operate those class of patients that can really benefit from this class of surgery. Now, these are the various associations in Asia that have got their own criteria. Look at South Korea. South Korea is type 2 diabetes with BMI more than 35. Uncontrolled type 2 diabetes is more than 30. Again, those are the guidelines they follow, which is even higher than the 27.5 that IFSO APC recommends. The Korean Society for Metabolic Surgery actually dropped it up to 27.5 BMI points, which was in line with the IFSO APC guidelines. Korean Society for Study for Obesity, again, was similar to the Korean Society for Metabolic Surgery. The Japanese guidelines, the Japanese Committee on Society for Treatment for Obesity, again, was much higher than the IFSO APC guidelines. In terms of China, the Chinese Society for Bariatric and Metabolic Surgery was again a guideline which was similar and in line with the IFSO APC guidelines. The Chinese Diabetes Surgery Society again recognized what we had already spoken about, 27.5 to 32.5 BMI. Not working. Next, yeah. And then we come to the new ASMBS and IFSO guidelines, which Lillian sitting here was very much part of. And what they've really recommended is basically that for Asia, the BMI threshold should be adjusted in such a way that you recognize clinical obesity at 25 BMI points. But you operate on patients with a BMI above 27.5. So we just heard Francesco deliver a great talk on what you define as clinically severe obesity. They've defined what you identify as clinically severe obesity. Now, this is the diabetes prevalence in Asia, and the reason why we're all talking about it is this, that the diabetes prevalence in the age group between 20 to 79 varies from region to region. It's around 8.3% in India, and that's the average cost a person undergoes when it comes to surgery. Now, if you look at the overall, this is a paper from Yi Chan that actually speaks about the BMI below 25 and BMI above 30. And if you look at the age, gender, ethnicity adjusted ratios, what do you find is that in both overweight and obese groups, the standard deviation BMI multiple variable analysis was adjusted for potential co-founders. And they didn't find too much of a difference, but they did say that overweight and obese subjects had a greater tendency to develop diabetes. Now, if you look at in terms of dividing between normal fasting glucose, impaired fasting glucose, or fasting hypoglycemia, newly diagnosed diabetes to previously diagnosed diabetes, and you just look at that BMI chart, you'll see that majority of them are above that 25 to 29 group, and then they go much higher. So all in that normal weight category is a different subset of type 2 diabetes that I don't think surgery can really benefit from. And I'll tell you why. Look at all these various papers. Jinji quoted a few papers. I just want to give you a long-term follow-up data. And all these various papers, from Kasama's paper to Ikramuddin's paper to Young's paper to Tang's paper, all of them talk about BMI above 28. That's 27.5 and above, except for Wei Jili's paper, which actually speaks between 25 and 35. And there, too, the majority of the patients were above 27.5. So we don't really have literature to say that this surgery works below 27.5. And look at this meta-analysis. Meta-analysis to meta-analysis, this is the one. Again, you have only Wang's paper and Lee's paper, which actually speak between 25 to 35. And again, self-admittedly, their number of patients below 27.5 was minuscule as compared to the number of paper. If you split these papers and go into the details, you will see this is Dr. Zhu's paper, and you just showed how many number of patients were actually below 27.5 BMI. Now, this is, again, from Korea. Professor Kim's paper, which shows about the mini gastric bypass, and the average BMI over there also was 27.2. That's around the 27.5. Nothing below that in all the various Asian papers. This is Professor Scopinaro's very famous paper where he did a BPD for the low age group. What they saw was at 1 year and 5 years, the type 2 diabetes control, which was glycated hemoglobin lower than 6, as well as the type 2 diabetes remission rates. And what they concluded was that in the BMI between 25 and 35, a positive metabolic outcome is less frequent than their counterparts with morbid obesity. Even all of us claim that BPD is probably the best surgery for remission of type 2 diabetes, we do agree in the low BMI it doesn't work as well. Type 2 diabetes mellitus in overweight patients, in spite of short-term normalization of the fasting hypoglycemia and HbA1c levels, well-sustained insulin sensitivity and long-term T2DM remain a majority of the cases. That remains the reality. So you've not really benefited the patients in any which way for the reason you've operated on these patients. This is the Bagua. Now, if you look at this, only 2 papers speak about BMI 24 and 26. All of them are above 27 BMI. So you don't really have evidence out over there to really substantiate a claim that you should start operating on patients between 27. Now, this is very famous. More than a lakh of patients, 94 published studies. Above 35 BMI, diabetes remission rate 72. Below 35 BMI, diabetes remission rate 71. So I completely say what Jinji said. Yes, operate below 35, but not below 27.5. Now, this is again, a systematic review and meta-analysis from Muller-Stitch's group. 5 RCTs, 6 observational controlled studies, over 706 patients with type 2 diabetes, average of 3-month follow-up. Metabolic surgery superior to medical treatment for short-term remission of type 2 diabetes and comorbidities. Further RCTs should address long-term effects and complications. Now, this was in the era where we did not have semaglutides, you did not have tirzepatide, you did not have cagrilintide. So what are we talking about? Well, in terms of eligibility criteria in this publication and meta-analysis from Bascota and colleagues, they say that patients with BMI less than 27.5 offered bariatric surgery in order to manage metabolic conditions such as uncontrolled diabetes. And the same hypothesis, anatomical rearrangement or modification would have beneficial effects. What were their conclusions? Well, they said the forest plots are completely suggestive. The study reported improvement of HOMA-IR, but C-peptide level was not changed. Now, ABCD score has C-peptide. If that does not change, why would you recommend surgery for this group? Again, total cholesterol and triglycerides were not changed significantly for the surgery. Again, reason you're operating is metabolic syndrome. You've not got a C-peptide change. You've not got a triglyceride cholesterol change. So why would you want to operate in that group? This is, again, the final analysis of their paper. The overall major complication rate for this surgery was 6.2%. Now compare that to drugs like semaglutide and tirzepatide. Will your patient opt for surgery is a question you need to ask yourself. Yes, you do have early remission of fasting hyperglycemia, but in the long term, this set of diabetics will not benefit from this surgery. So according to Clark and colleagues, the lowered cutoff values may not be suitable for Asians. While the lowered cutoff values by 3 units seem appropriate for the Hong Kong Chinese, the Indonesians, and the Singaporeans, the BMI cutoff value would be too much of a drop for the Northern Chinese and Japanese. And that's what Jinji was trying to show. So you're not even benefiting all the Asians, even within Asia, with this. So there isn't enough evidence to support the beneficence of metabolic or bariatric surgery in Asian patients with BMI between 25 to 27, and they should be treated with lifestyle modification. And that's my conclusion. So dropping the BMI further than the current limits of 27.5 will not add significant to the group of patients we want to benefit. It will not add numbers because we already have such a large pool and less than 0.1% of these patients are getting operated in Asia. And drugs available currently will target you and will be far better with almost no complications there in the long term. Thank you.
Thank you, Murphy. Now we discuss in detail. First is Dr. Edva Onivar from Philippines. Yes or no? Okay.
Hello. Good afternoon. I'm Dr. Oliveros from the Philippines. And I'm just going to base my discussion on our two yes and no presenters. I'm not going to take sides, although it's a very touchy topic. This whole week, we've learned a lot on low BMI. And today alone, if you were listening to Dr. Rubino, the trend now is it's not to base everything just on BMI. We should be more looking at clinical obesity, the indicators for surgery. And I just want to make some comments on the low BMI, at least 27 below, offering a gastric bypass. There's really not much evidence on that. And offering something as big as a gastric bypass to a low BMI patient will be quite difficult. I come from the Philippines, and our diabetes rate is 6 to 8% in the general population. The obesity rate is around 10 to 12%. It's not as high as all other countries, but generally it's low. And offering surgery to these low BMI patients from 25 to 7 is going to be very difficult. Right now, I cannot find an endocrinologist who would refer to me for patients in that. Given now that the drugs we have are so good, well, for low BMI patients, of course, that's what they're using these drugs are, those GLP-1 agonists. And it works well for them. To find a patient to convince them to have surgery is going to be difficult. But then again, as the no presenter said, the evidence is still not there for low BMI. There's still not so many studies to offering surgery to them. So really don't know in the next few years if it's offering surgery to them is going to be the way to go. Based on what I've also learned in this convention, there's this obesity or even low BMI patients. We should be treating it as a disseminated disease, offering them neoadjuvant before surgery. So like cancer. So probably for these low BMI patients, I think the way to go is still to offer them medical therapy with those GLP-1 analogs. And then let's go and see how far they go with that. Of course, they cannot lose weight forever. You can't take those drugs forever. Probably that will be the time surgery might be offered to them. But I'm doubtful if it will be a gastric bypass. We should offer something less drastic than that. It could be the sleeve, I don't know, or the other endosurgical procedures. Last among all, I guess really have to select our patients those who are diabetic, definitely, if it's just pre-diabetes or early diabetes, less than 2 years, probably they're better off offering, giving them medical therapy first. I think, for me, that's just my opinion. I really can't say for others. That's what my opinion is.
Thank you. The next discussant will be Dr. Harry Frydenberg.
You could face everyone. Harry, you could face me.
Well, both of you presented your discussion, your arguments fairly well. It was good scientific-based articles that you quoted and all the rest of it there. There were a few questions that I just wanted to know. You both discussed the main comorbidity of diabetes. The question is, how would it affect other comorbidities? I wanted to ask you both, were there any other comorbidities you actually looked at in relation to the BMI and the operating on below the 27.5? Were there, or?
The Scopinano's paper did look at some of them, but majority of it was for metabolic syndrome. They didn't look at NASH or NFLD that point of time. They didn't look at the uric acid levels. So it was mainly dyslipidemia, hypertension, and type 2 diabetes. And in diabetes, they split it in terms of fasting hyperglycemia, HOMA-IR, C-peptides. That's what the aim of the studies were so far. So I don't know whether other comorbidities do exist in that low and overweight category of patients. Harry.
Right.
For the lower BMI, lower than 27.5, I think the most common comorbidities should be type 2 diabetes and hypertension. And for this population, maybe I agree to the doctor, to the discussion from Philippines. Maybe from this population, for now, GLP-1, a lot of GLP-1 maybe achieve a good outcomes. But I present the papers also maybe 5 to 10 years ago finished the studies. So at that time, we always do the Professor Drew always do the gastric bypass, no sleeve gastrectomy.
Well, that is really the comment. The comment is the fact that in time, things have changed.
Okay.
And all the other aspects of the way we thought 10 years ago, 15 years ago, 20 years ago, obviously has changed. And with the advent of the new medications that are available, and I think Eduardo Oliveira's talked about this and obviously gave a good idea that now, today, in this era, we have to look at the alternatives. The less invasive, and this is what the tendency has been all around, the less invasive procedures that we do, the better under these circumstances. And as you say, when you're getting to a BMI, well, 27.5 has been adopted even with the new ASMBS guidelines. You may consider reducing it a little bit more, but certainly not very much more at this stage. So overall, in relation to the argument, I won't take sides except to say that, we're tending not to get as invasive procedures as we have in the past. Thank you.
Thank you, Harry. Next, please, Professor Mohammed Tabo from Iran. Okay.
Hello. Thank you very much for your very nice lecture. I have to say that in my country, the rate of diabetes is very high. In some cities, up to 20%, something four-folds more than general population in the world. And so there are a lot of patients that do like to do operation to get safe from diabetes. In our criteria, we do like to make sure that there is enough C-peptide and free C-peptide in these cases, that the reason of diabetes is related to second form of diabetes, and the pancreas has enough insulin to be secreted. So it's very important in low BMI because it's not related to obesity, it's maybe related to other factors. And make sure that the result of this operation is effective in this patient is very important by this study, by these laboratory studies. And I do, in these cases, very short biliopancreatic and alimentary tract to prevent any weight loss, any prominent weight loss, just to solve the problem of diabetes. And if we focus on diabetes, I'm in favor of this work, especially in cases which are under insulin injection and the rate of diabetes is very high. But for example, sleep apnea or for hypertriglyceridemia or hypertension is under question because this operation is not so has not so dramatic effect on these complication, comorbidity, including hypertension. But sleep apnea in low BMI has another reason, and weight loss maybe has not any effect on these major comorbidities. I think we can, this is an important challenge, and we can think more about especially diabetes in low BMI cases if they complain prominent diabetes with insulin injection, with positive more than one C-peptide, which we can guess that the result of operation is good. I'm in favor of this operation. Thank you.
Thank you. Last but not least, Dr. Sang-Kwan Lee for his opinion.
Yes, Dr. Lee from South Korea. A very interesting discussion and very debatable topic. In fact, in Korea, the national insurance coverage is from 27.5 with uncontrolled diabetes. So we are awaiting for the result of a registry, and that could partially answer this question. And about what you mentioned, Mufi, Dr. He had subsequent result of his paper with 105 people with BMI average 25 and had a 3-year follow-up data with a remission rate of 90% of diabetes. So a well-designed study would be required for answering this question. And also, this would be a very nice moment to invite endocrinologists to discuss about this topic, because finally the endocrinologist will be the doctor who send patient to the surgeons. This is my opinion. Thank you.
Thank you very much. Now, ladies and gentlemen, you've heard both sides of this argument, the yes and the no, and the discussion from 4 experts. I'd like to show a hands of who agree with Dr. Yang that it's a yes. 1 hand. Does that mean all the rest of you are no? No's?
No more.
All right, thank you very much. Thank you to Dr. Yang and Dr. Mufi.
Thanks.
Thank you. I'm going to invite my next moderator to come and replace me.
Katsu, please. Okay. Thank you.
By the way, is Dr. Shahabi in the room?
Yeah.
Ah. Well, congratulations for winning the APC scholarship.
Take a few seconds. Okay, we move to next topic. Next topic is should Asia patient reduce BMI from 35 to 32.5 for metabolic and biological surgery? Okay. moderator Kazu and I and me.
Okay. So thank you everybody for coming this session. I'm sorry to say that Wei-Jie Lee already left, so that he asked me to find someone replace him. So I appointed Dr. Oshiro, Takashi Oshiro, replacement of Wei-Jie. And then Wei-Jie gave him his slide. And I would like to have a brief introduction of Takashi. Takashi Oshiro is my first bariatric fellow for 17 years ago. So that means that he is the first Japanese bariatric fellow. So that he had experience of bariatric surgery 17 years. So that he is suitable person to have this talk. So, Oshiro, please start. Mike, please. Mike.
Okay. Okay, thank you. It's the first slide. So thank you very much for giving me the opportunity to speak on behalf of the Wei-Jie Lee. And all slides are prepared by Wei-Jie Lee, and I will do my best to present in line with his intentions. So, but today's outlines. For decades, it has been suggested Asian phenotypes of type 2 diabetes. That characteristic Asian phenotype is young onset, occurrence at the lower BMI points, and long disease duration place the Asian patient as a higher risk of cardiorenal complications. So in any ethnicities, increasing in BMI at the risk of developing type 2 diabetes, but Asian develop type 2 diabetes at lower BMI points. So why the push for the lower BMI cutoffs for bariatric metabolic surgery, especially in Asia? So Asians face Asian faces risk of developing type 2 diabetes. Same risk, Asian BMI 24 and the Western BMI 30. So this is a slide of a distribution of a BMI in Asian type 2 diabetes. If BMI over 35, only 2%, less than 2% over type 2 diabetes. In the BMI 30 to 35, and 9%. And if we extend the BMI to 27, the 25% of type 2 diabetes in Asia is there. So young onset diabetes, diagnosed diabetes before age 40 is another problem. So it is true, 20% of Asian type 2 diabetes patients experience young onset diabetes. So young onset and poorly controlled diabetes are more likely to lead to a diabetic nephropathy, even with very short durations. So same is true for the hypertension. Increase in pre-obese BMI raises the odds ratio. So I introduced baseline research by Wei-Jie Lee. Diabetic surgery study was conducted at 4 sites in Taiwan and the United States. This is a randomized control trial, laparoscopic and gastric bypass versus intensive medical management for the treatment of type 2 diabetes. In extended 5-year follow-up, the surgery group continued to demonstrate better results of controlling glycemic control, lipid, and blood pressures. So this is a sub-analysis of a DSS was conducted for individuals from Taiwan and the United States. Baseline characteristic, Taiwanese obese patient, younger and lower BMI and shorter duration of type 2 diabetes compared to the counterparts American. So this slide shows a remission rate 2 years after the Lewy gastric bypass. So Lewy gastric bypass seems to be more effective to control glycemic control for Taiwanese. And with respect to predictors of remission of type 2 diabetes, nationality is not a significant difference. But the C-peptide, one of the indicators of insulin circulation, is a very important player to predict the type 2 diabetes. So now we are talking about procedures. So Weijie Li, 15 years ago, Weijie Li already reported effects of a mini gastric bypass in the patient BMI less than 35. That concludes a patient with BMI less than 35 has slightly lower response rate compared to the higher BMI, but there's still high success rate, 78%. So Weijie Li also reported this paper that concludes gastric bypass surgery had a better result in type 2 diabetes cure rate than VBG and gastric banding. So how about the laparoscopic sleeve gastrectomy for non-morbid and obese patient and poorly controlled diabetes 2 patients? The remission rate of type 2 diabetes was up to 50% 1 year after the surgery. And yes, sleeve is also improved the insulin circulations, but C-peptide 3 or higher is most important factor to predict type 2 diabetes remissions. Yes, this is a Weijie Li. Again, the Weijie Li's randomized controlled trial for type 2 diabetes treatment, sleeve versus gastric bypass. For the 60 moderately obesity, Taiwanese BMI 27 to 35, and who had a poorly controlled diabetes. So this is a 1 year outcomes. Patient assigned to a gastric bypass had patient assigned to gastric bypass had lost more weight. This is a pink line, and achieve the more likely to achieve a type 2 diabetes remission in a brown dot. This is a 5 years outcomes. Of course, sleeve is very effective, but mini gastric bypass more likely to achieve type 2 diabetes remission and had more incretin effect on insulin and C-peptide. So now we know the bypass surgery is good for the mild obese and type 2 diabetes in Asian populations, but the gastric cancer is still a problem. To solve the problem, sleeve DJB was introduced by Dr. Kasama, and that is one of the bypass surgery. The concept of mechanism on metabolic effect is like Lewy gastric bypass and mini gastric bypass. Finally, we are talking about the preoperative predicting scoring system. So using the Asian data, Dr. Weijie Li first published the ABCD score in 2013, which is a scoring system composed of age and BMI, C-peptide, duration of type 2 diabetes. And he modified the ABCD score in 2016 with more precisely adjusting BMI and C-peptide and duration of type 2 diabetes, considering aging characteristic of type 2 diabetes. So compared to the original ABCD score, modified ABCD score predict more precisely in the patient with a poorer score. So there is several predicting scoring system in the world, but background of a development scoring system is quite different. ABCD scores comes from the Asian data, and DRM score and IMS score from the United States. And DRM score and IM score also include the medication type, and so we cannot deny the preference, physician's preference over bias. So comparing to DRM score and ABCD scores for Taiwanese obese and type 2 diabetes patients, DRM score overestimated type 2 diabetes remission in a patient with a poorer score. But in contrast, modified ABCD scores more precisely predict the type 2 diabetes remission in a patient with a poorer score. And also comparing the IMS score and the ABCD score. IMS score cannot differentiate the difference between the sleeve gastrectomy and bypass, but ABCD score can differentiate the remission rate of between sleeve gastrectomy and bypass surgery. So in conclusion, we can say the lowering BMI is reasonable, and bariatric metabolic surgery, especially bypass surgery, is good for the mild and diabetic obese patient in Asia. And finally, ABCD score is excellent. Thank you for listening.
Thank you, Dr. Hashiro. Dr. Ashim will say hello, please, from Singapore.
Hello, good evening. Thank you very much. Sorry, I'm not appropriately dressed for the occasion. I thought I'll get back to the hotel dress up, but I couldn't dress.
So Master Low.
There we go. Now at least we are on equal playing grounds. All right. Thank you very much. That was an interesting way of presenting data, and none of your faults. Prof. Vijay is not here, so we couldn't have that heated thing. Most of the data you have presented is based on indications. It's indicated this, it's indicated this. I like to see outcomes. I think I'm a bit more pro. BMI, just to be more inclusive, having 1.85% of population to come down to 8.5, but out of the 1.85% of the diabetic population, how much have we actually served? In actual fact, the answer is we know very little. So that's my case mix. Sorry. Am I going? I'm going the wrong way. That's why. All right. So that's my case mix. I have no conflict of interest for this talk. Upfront, my answer is there's no need to reduce below 35 when we keep 32.5 in mind. And the first response is, come on, guys, it's already done. We have 15 years, 2 decades into the thing. We're still discussing it. I don't think I should be discussing this. It's a done deal. Nonetheless, let me try and give it a shot. This is what the latest guidelines say. Reduce it by 2.5. But the very fine print of this, when you read it and you look at it, is actually they're suggesting that 25 and above should be considered obesity and not overweight anymore. But nonetheless, I defend my point. And this is all the clinical indications. As I said, it's already a proven fact. I'm not show why I'm here to argue about it. One of the earlier publications, Mufi, you must remember to quote this publication. This is by yourself in 2010. You quoted to 2011 or 12, but this is a more earlier publication than that you published. And so it's a long gone story. So now let me say, what are we trying to achieve by lowering the BMI? Are we trying to prevent disease if we're talking about bariatric surgery and not metabolic surgery? If the whole idea of bariatric surgery is that I can reduce a patient's weight and he will not develop comorbidities after that, my question is, where is the data of prevention? SOS study has clearly shown in a cohort study that if you operate on patients and continue to follow them up, there is a prevention. Where is that data in low BMI? Do you have it? No. So should we recommend weight loss purely based on that? All right, let's think again. All right? Is it the patient, him or herself, is asking, is this really the right choice I need to make? We've been hovering about metabolic surgery. We've been talking about bariatric surgery. Is metabolic bariatric surgery only about diabetes surgery? Is that the only endpoint that we are trying to treat? What about all these? Where is data for other metabolic diseases, sleep apnea? Where is data for hyperlipidemia? Where is data long-term for hypertension, for many, many more metabolic problems? Where is data for osteoarthritis? Where is biochemical data for decreased inflammation? Where is data for cancer? Where is data for psychological quality improvement in life? Do we have any? We're recommending, right? We're making a recommendation. At least for 35 and above, it does exist. For 35 and below, it does not even exist in an Asian population. You want to recommend it? Well, that's not fair. What is it? If we're even talking about diabetes and metabolic diseases, what does it take for a person to actually lose weight? To actually find what is it that the patient wants? Resolution of his metabolic problem. How much weight do you need to lose? 5%. Do you really need to operate on a person to get 5% weight loss? The poorest and the poorest of medication gives you a 5% weight loss. And it's easier when the BMI and the quantums are low. Do you really need to operate below 35 point something? Well, these are the drugs. These are what they show about the change in weight all the way down to semaglutide, and you can see coming into the picture. Each and everybody losing at least 7.5% of their weight, 4% in naltrexone, even metformin giving you a 2.5% excess weight loss. Do you really need to operate below 32.5? All right. Well, you can say, well, Asim, that was history. Let me give you a new drug. There's tirzepatide. Okay, 40% excess weight loss, if I'm not wrong, or minus 20 kgs% of total body weight loss. Is that what surgery is going to achieve? Then why do I need to operate? Shall I ask not to reverse the guidelines from 32.5 to 35? Now I have better drugs to treat the patient. So let's go back and reverse the guidelines from 32.5 to 35 instead of leaving them and put patients on tirzepatide. Why are we fighting for lower values when we have better drugs? All right. So low BMI, multiple comorbidities. Will it really reduce my risk? We're not talking of prevention anymore. We're talking of risk reduction. Are we going to get it? Any data out there? No. Well, if the answer to all the questions is no, then I think 32.5 should become 35. All right? I'm not advocating to keep it. I'm advocating to reverse it. So thank you very much. I rest my case to you.
Thank you, Asim. So that, both of you stand there. And as a discussant, the first discussant was Dr. Sudachi, but he's not here. So I asked Dr. Tejana from Sri Lanka to be a discussant. So that please have your comment, Tijana. Thank you.
Yeah, thank you very much. Yes, so excellent talk, both of you. Of course, it is vigilist talk. Yeah, that's right. But see, it's interesting point that Asim has brought, whether we should actually, we are talking about guidelines saying now 27.5. Actually, I was also scratching my head when that guidelines came out, because you see, I never wanted to talk about that even in any of the meetings in Sri Lanka, because the physicians will crucify me, you know, physically crucify me if I talked about 27.5. Because as Asim said, a very valid point. You see, let's drop all this thing about the Asia Pacific guidelines and the IFSO guidelines for the rest of the world. In the Asia Pacific countries, of all us Asians, how many of us are actually able to give a bariatric operation or a metabolic operation for just BMI 40 and above and 35 with comorbidities? The classic IFSO, the WHO guidelines. How many? The answer, except in very few countries like Hong Kong and so on, the answer would be we are way undertreating even at 35, keeping it at 35. Because still the physicians are not referring. I'll be very surprised. Even in India, the situation has changed where so much bariatric surgery is happening. When I talk to them, still, I mean, nobody's getting this so-called exclusive or elusive group of, let alone 27.5, but the BMI 32 and comorbidities. Still we are struggling to operate on 35 with comorbidities, right? I just was on the phone, frankly, with a patient that I'm going to operate in 2 weeks' time. When I'm going back to Sri Lanka, I have to do 12 cases. This guy is at the moment BMI 41, and already he just called me to say that the physician has discovered that is diabetic, he's developing diabetic renal problems. Already it's shown on the blood test, but the physician is still trying to convince him to lose weight in other methods, including the medication, the new medication, because this is a new problem, right? I think with the new drugs, just remaining at 35 will be a challenge for us, like the countries like Sri Lanka and India, for example. I don't know about the countries like Hong Kong and Singapore, the high-end countries. So therefore, ladies and gentlemen, I think at least we'll try to hold our feet at the 35 and 32.5 level rather than trying to talk below, because we don't have adequate data to as evidence.
Okay.
Tejana, yeah, the conclusion is you need to stick to 35.
Yes, that's right.
Okay.
We need to stick to 35, because even to 32.5, the evidence that we have at the moment, are quite debatable. They are not adequate to push for even that level, let alone coming down.
Okay, good. Thank you. So the next discussant is Simon Wong from Hong Kong. Please give us a comment.
Thank you. I look at it in a slightly different area, because when we look at the title today, the first discussion is about diabetes. So I suppose this discussion of 35 to 32.5 should be excluding diabetes. But at this moment, I think all our guidelines, since from the APC and ABMHS, we use the 35 without comorbidity and 30 with comorbidity. So now the topic is 35 to 32.5. So it means that we are talking about operating low comorbidity, but with lower BMI. So I thought this is the discussion whether should we operate on them. If you have comorbidity, I think most of them already operating on 32.5, right? In Asian, in
So
some.
the title reads metabolic and bariatric surgery. So that's why I pitched it at both, which is give me answers for both sides.
Yeah, so I think if you have metabolic disease associated, I think 32.5 is very, very valid to be treated. And if you're talking about 32.5 without comorbidity, whether we should treat them, at this moment, of course, we don't have much data very specific for this kind of patients. But I don't know other part of the world, but for Asia like Hong Kong or Chinese or India, I think it's quite difficult if you find a patient 32.5 and then you test all the blood tests, all the liver function and all the blood pressure. Sometimes it's difficult to find that they don't have comorbidity. Or maybe when they're young, when you do this, they may not have, but I would say 10 years later, they will have hypertension and hyperlipidemia and so on. So the difference is only 2.5 BMI, and the impact of treating them early actually is for us. We know that there is benefit, but we just don't have the data. So that's why in the IFSO and AVMSS guideline, they try to lower their BMI from 40 to 35, from 35 to 30. So, but if you look at the guideline for the section of Asia, the indication is very bare. They just say you have different BMI criteria, so you need to think about your own criteria by allowing more patients to receive surgery. So I think this area at this moment, even we discuss here, is still without much lots of evidence. But I think within our APC chapter, maybe in the future, we should revisit it and set up a more clear Asia guideline. Because even in my country, in Hong Kong, we are still discussing whether to operate on 27.5 without comorbidity. Because now, I mean, if with comorbidity, like hyperlipidemia or hypertension, because now that's what the Western guideline, obese one with comorbidity, we should operate. So I have no answer, but I agree with decreasing the BMI.
Okay, thank you. Next one is Professor Jung Hong Lee from Korea.
Thank you. I'm Joe from Korea. Regarding the cutoff value of 32.5, I totally agree with Dr. Hashim that because I think we need some more time to gather collecting the data about the patient group. But in the near future, I'm sure that we will have good data for this BMI group. So in the near future, the guideline can be changed. The most important thing is the science-based evidence. We have the evidence. For the rest 10 years, there are so many guidelines regarding the operation for the class 1 obesity. Even the KSMBS, ASMBS and IFSO also have announced their position statement regarding class 1 obesity. And the updated guideline is very identical to the previous ones. I was very curious why they have to do that work. Why there is some reason or some purpose to make this joint guideline? What's the reason? What's the purpose of this one? I thought, what was the reason? Maybe the authority or power of the guidelines. Why we make an effort to make guidelines? What is the guideline for? I think this guideline should not be only surgeons' league. It should be accepted and approved by other society or general population or the provide insurance or policymakers. So, based on the things, the most important, we have to persuade and negotiate with the other persons. The most important thing is we have the evidence. Scientific evidence is very important. Dr. Kasama, what is our next step if the other society or the insurance reject or refuse this guideline? What's our next step? What can we do? I was very curious of that.
Thank you, Joho. So the next discussant, Mohit is not here, so that I ask Dr. Peters from Indonesia as a representative of Indonesia. So give me as a comment.
Thank you, Dr. Kasama. I must say that both of you are very convincing. Yeah, after the first percent, I would be sure that should be lowered. But after Asim, yeah, I had some doubts. But I think, in my opinion, do we still need for data? Yes, of course we do. But waiting for data and evidence may be too late for some people. We have about 3 cases a day for bariatric surgery. And a lot of those patients are coming for surgery for diabetes. And currently, we are still rejecting patients, even for BMI 33 without comorbidities. And sometimes these patients come back in a few years with diabetes. I think I'm for lowering the BMI to 27.5. I think it's yeah, it's not fair for those patients who are in need for this type of surgery. Thank you.
Thank you. The next one, Dr. Kazu, what's your opinion?
So actually, many of you think that this question, so should the Asian patient reduce BMI from 35 to 32.5 for metabolic and bariatric surgery? That the question is not very good. It will make some confusion because we need to focus on the metabolic or bariatric. So talking about the metabolic surgery, of course we have to reduce because for these 20 years, we much focus on diabetes. So talking about diabetes, it should be reduced, but as you guys say that without comorbidity, so-called the weight loss surgery, used to be called weight loss surgery. At that time, so BMI 35 or 32.5, we still don't know the data that which is appropriate for the Asian. Because usually for the weight loss surgery, I mean the term of weight loss surgery is not the proper now. So bariatric surgery to reduce the weight is for the weight problem like a joint, I mean the arthritis or sleep apnea, something like that. Of course, including psychosocial problem. So at that time, we still don't know the data regarding reducing BMI is beneficial for our patient in Asia. So from the viewpoint of the weight loss, we still don't have a clear data for Asian. So that, sorry that this question was made by us. So, and it makes you some confusion. So But my opinion is regarding a metabolic surgery, we should reduce more. 32.5 is not good enough for our patient, diabetes patient. But for the bariatric surgery, we still don't have a data. So that as a IFSO APC chapter, we think we need to make our evidence regarding the weight loss for which kind of patient is properly selected for weight loss. That's my opinion.
Can I have a comment?
Sure.
Right. So debate apart, that was debate, and we just had sparred for the reason of debate. But what is critical to understand is that the guidelines has empowered the community with a very strong tool. It is up to the community in this hall and out there within Asia to prove and to produce evidence that what they have done is right. Because over time, when we treat our patients, today when we sit on this table, we talk about metabolic bariatric surgery. Metabolic surgery to us is diabetes. Tomorrow, there will be people who will be operating at 27.5 for infertility, for gouty arthritis, for sleep apnea, and there will be morbidities that will be happening. We will go back and these won't be reported. And then there will be a huge hue and cry. So the onus as a society, it's ours and everybody's that we report data truly so that we know what the true fact on the ground is over time. We need also to back these studies not only clinically, but also through substantiate through mechanisms that really is in metabolic surgery is the balance between insulin resistance and insulin production failure really there? And the surgery overpower that benefit. I mean, Kasama studies have shown that. But in other studies, we need to continue to show that it makes sense. And why does it make sense? The science behind these science needs to be produced. And since the responsibility and onus lies with the community that wants this, we have a duty of care to our patients, and we should produce that science as well. So if we all partner in it, we can produce good outcomes, we can rationalize our selections and fit it to an appropriate patient, and it will truly be a tailor-made approach. Thank you. Thanks, Kazama.
Good, Asim. So, Takashi, do you have some comment?
Yes. I also respect the results of data, but we need alternatives for treating such kind of the patient. So I think we don't need to wait their weight reaching BMI 35. And now I know the promising new anti-diabetic drugs with body weight loss effect. It's promising, but it's very expensive. It is difficult to continue for lifetime. It's we're thinking about the 90 million diabetes patient in Asia and 20% in the young onset. So prescribing new anti-diabetic drugs for such kind of the patient is a bit strange for me. So personally, lowering BMI 2.5, I think I don't think a matter.
You think that the 2.5 is not enough?
Maybe no. Just a 2.5, it's not a matter. I think. Just lowering 2.5, maybe 8 kilo or something. It's not a big issue. Personally, I think. So if we perform such kind of a patient surgery, maybe they gain the weight to reaching at the BMI 35 in the near future. So we usually need alternative, maybe drug therapy, but it's very expensive. So I think I recommend the patient surgery, such kind of the patients.
Okay. Thank you. I think in Asia and IFSO APC area, maybe two different concepts. Because in Australia, maybe mainly is Caucasian people. In Asia, we know the very high population. South Asia, East Asia, West Asia, West Asia, maybe different. So we can say this conference, the new guideline, many sessions focused on the new guideline. It's very important. So for us, how to diagnose obesity, how to treat it. So include lifestyle change, or medicine, or surgery. So very, very important. So I ask everyone, if you agree, Asia patient, no comorbidity, reduce BMI from 35 to 32.5, please, up your hand. No? Which one? Don't agree with? How many people? Maybe agree is more. Okay, I think maybe we need more evidence. We need more long-time follow-up and more RCT. So thank you, everyone. Maybe we take a picture. Every speaker, every discussion, yeah, also together. Come, moderator, Ninian. Okay.
Okay, so thank you so much. We need to close this session because of the time. And I would like all the speakers and moderators and the discussants come up to the stage in front of the screen, and I would like to take a picture. Thank you.